Hi friends, I'm Dr. Ashutosh. Or now let us talk about the preeclampsia, right? Okay. So the this maternal fetal medicine has advanced to that great extent that probably what we have done is this, that we are trying to decrease the neonatal or infant mortality. Similarly, the maternal mortalities, they have been also reduced. So meaning thereby that we are definitely in a position so as to pick up the IUGR babies, asymptomatic IUGR, abnormal Dopplers, and similarly we are able to identify the preeclampsias, the PIH, pregnancy-induced hypertension, and when the mother loses some protein into her urine, and therefore it is called as a preeclampsias and all those stuff, right? But still, this PIH and preeclampsia is the leading cause of a neonatal and a maternal mortality, meaning thereby that there is a lot of etiopathogenesis into all this stuff, and therefore it could be syndrome X, it could be metabolic syndrome. The mother is not able to make some blocking antibodies, and therefore there is sort of a less invasion of the trophoblast into the maternal decidua and into the spiral arteries of the uterine arteries, and so on and so forth. So probably we can have a lot of etiologies and all this. So let us be into a clinical part of it. So how do we can identify and can segregate those cases which is a high risk of landing up in the preeclampsia, and therefore we can start with a low molecular weight heparin, and therefore we can preempt, and therefore we can tell us as a clinicians, as a fetal medicine specialist, or we can tell to the patients and we can appraise them, we can make them understand that you stand at a higher risk, and therefore we are in a strong vigil, we are in a strong surveillance so as to see the mother and the baby, so as to identify is everything fine with the baby, right? So I have had a lot of videos regarding this quadruple marker, but now we are discussing these two cases, and probably I do have that one case more. Probably I'll make a video separate for that, but probably we are going to discuss these two cases today, and that would make it amply clear that we can take the advantage of a very basic test so as to identify what is happening to the baby. So look closely. This is the first case that we are seeing at 12 weeks. We are doing the right uterine artery. So the RI is somewhat 8.8. And then we are seeing for the left one. So this is also high. We are keeping the patient in a follow-up. Then probably we are seeing, so this has become better, but still it is high. And then we are doing, so this is also on the right hand side, and this is also high. This is at 19 weeks, and 0.53 is the RI, which is well within the normal range. And this is the quadruple marker. So probably we do the AFP and the dimer inhibin A, and therefore they are normal. This is the case 2. You see that this is the right, and then this is the left. We are having a post-diastolic notching. And you see the quadruple marker, and the alpha-fetoprotein mom is 3.81, which is very high, and therefore she is a very high risk for preeclampsia. So we are doing the nuclear scan at 12 weeks, and and then all the pregnancy ultrasounds at level 1 are being complemented by doing the uterine artery Dopplers, and the uterine artery Dopplers, they can pick up the high uterine arteries resistance index or the persistency index, which is called as an RINPI. So we do have those nomograms, very well established nomograms, and once it is high, then probably we keep them in a follow up, and then we ask them to see us back at 16 weeks. So in 95% of the cases, what we believe is this, that it falls naturally. Uh, uh, I do have had a video in which I've explained the Posselis phenomenon, meaning thereby once the diameter increases, diameter of the uterine artery increases by half, the resistance falls by four folds. So meaning thereby that before starting with anything like low molecular weight heparin or raising a red flag or making them aware that there could be high risk, so probably we always wish them to see us back at 16 weeks, and we do the Dopplers. If the Dopplers are abnormal, then probably we'll ask them to do a quadruple marker. This is a very basic quadruple marker, because since we see the four hormones, we call it as a quadruple marker. And then we do have those nomogram values available to us. So if the MSAFP or the AFP mom is greater than 2.5 and dimer A mom values are greater than 2.5, then it is a they are abnormal, and it is a very high risk for her to end up with a PIH or a preeclampsia. So in cases in which the quadruple marker is normal, what we feel is this, what we believe is this, that the fetus and the mother, they talk through the level of the hormones. How I'm talking, how somebody else would talk, whether it is an Arabic or whether it is a Malayali or a Kannadi. or English or vernacular or Hindi, how we are talking. Similarly, the baby talks to the mother through the level of the hormones. And if the values of those hormones are normal or well within the normal range, we believe that the uterine arteries would fall into a normal range. Okay, so meaning thereby that the fetus or the mother landing with a severe PIH or a preeclampsia and landing up at 28 weeks with absent diastolic flow, the possibility is very negligible. So in the first case, what we identified is this, that the all the four markers, the quadruple markers, they were well within the normal range, and therefore we have seen that from the 16 weeks the Dopplers were abnormal, but at 19 weeks and 5 days at the time of the level 2 they were absolutely normal. Both RI and PI, they were at the 50th centile of 0.53. Vis-a-vis in the second case, we've identified that the AFP mom values was 3.8, and it was a high risk for a neural tube defect. It was not the neural tube defect. It is not a neural tube defect in the fetus, but since the values are very high, and therefore it is showing us that it could be a neural tube defect. uh, but the thing is this, that it is a marker for an abnormal blood flow or a uteroplacental insufficiency. So meaning thereby that we have made them understand that you being at a high risk for an IUGR, asymmetrical IUGR, and landing with a pregnancy-induced hypertension or preeclampsia. It is all better that probably we start with a low molecular weight heparin. Once it starts, probably it has to be taken up to 34 weeks, and we do have our titration values like zero point 0.4, zero point 0.6, 0.8, and that has to be taken BD. So there are a lot of things, and a lot of juggling with the dosage and the low molecular weight heparin and the equipment they needs to be done, and we need to keep keeping the pregnancy under surveillance. So one basic test known as a quadruple marker, you forget about the false positivity for the Down syndrome, but we can take this advantage of doing this quadruple marker so as to ascertain and so as to see, so as to pinpoint and so to highlight the high risk cases which are very very high risk to land up with an PIH and preeclampsias and very severely IUGR and asymmetrical IUGR babies, and therefore we can make them aware that all these things they can happen at 28, 30, 32, and we can take those preemptive sort of a diagnosis, and then we can preempt by doing and giving them low molecular weight heparin and all the stuff. So probably we can change our management depending upon this. So this is how the portable marker changes our complete management regarding the pregnancy. Right? Thank you very much for your question, listener.